Hey, future nurses, I'm Jenny with Study Nurse IQ. Today, we're diving deep into the powerhouse medications known as Angiotensin II receptor blockers, or ARBs. These drugs are a staple in cardiovascular care, and you absolutely have to know them for your nursing school exams, NCLEX, and your practice. Stick with me until the very end because we're not just going to cover the content. We're going to use 3 NCLEX-style questions to test your knowledge and cement your learning. Let's get started. As always in our pharmacology series, we use the nurse mnemonic to organize our learning: name, use, responsibilities, side effects, and education. We'll start with N for name. The family name is ARBs, but the generic names all share a giveaway suffix, Sartan. When you see losartan, valsartan, or olmesartan on a medication list, you know immediately that you are dealing with an ARB. To understand ARBs, we must first understand the system they interrupt: the renin-angiotensin-aldosterone system, or RAS. Think of RAS as your body's emergency system, its panic button for low blood pressure. When blood pressure drops, the kidneys sense it and release renin. This triggers a cascade that results in the creation of angiotensin II. Angiotensin II is the bad guy here, the master constrictor. It has 2 main jobs. It is a powerful vasoconstrictor that squeezes blood vessels tight to raise systemic vascular resistance. And it triggers the release of aldosterone, which tells the kidneys to hold on to salt and water and excrete potassium, ultimately increasing blood volume and therefore blood pressure. This system is great if you're hemorrhaging, but terrible if you have chronic high blood pressure or heart failure. Here is where the ARB comes in. The ARB doesn't stop angiotensin II from being created. It simply blocks the receptor sites where angiotensin II needs to attach to do its work. Specifically, it blocks the angiotensin II type 1 receptors. Imagine angiotensin II is a key. The AT1 receptor is the lock on the blood vessel. The ARB acts like gum stuck in that lock, so the key can't turn it. The result of blocking these receptors? Instead of vasoconstriction, we get vasodilation, which decreases systemic vascular resistance. The release of aldosterone is suppressed, causing the kidneys to excrete salt and water but retain potassium. This decreases overall blood volume. The beautiful end result is a significant decrease in blood pressure. You may be wondering how this is different from an ACE inhibitor. This is a huge point for your exams. ACE inhibitors, the prils, block the creation of angiotensin II. ARBs, the sartans, block the action of angiotensin II. Why does this matter? ACE inhibitors interfere with a substance called bradykinin, which is often what causes that annoying, persistent, dry, hacking cough. ARBs do not interfere with bradykinin, which means the cough is highly unlikely with an ARB. Therefore, if a patient develops that dry cough on an ACE inhibitor, the physician will almost always switch them to an ARB. ARBs are used to treat 3 major conditions, all related to lowering resistance and pressure. First, hypertension. This is the primary use. By promoting vasodilation and decreasing blood volume, ARBs are very effective at lowering blood pressure. Second, heart failure. ARBs are critical here because they help the damaged heart pump more easily. They decrease afterload, the resistance the heart has to pump against. They decrease preload, the volume filling the heart. Lower afterload and preload means the heart works much less, improving cardiac output over time. Third, diabetic nephropathy. This is a key benefit. In type 2 diabetics, high blood pressure damages the tiny filters in the kidneys. ARBs lower the blood pressure specifically inside the kidneys, which decreases the amount of protein leaking into the urine. By doing this, ARBs actually help to slow down the progression of kidney disease. As the nurse, your responsibilities center around monitoring for 3 major high-risk areas. First, high potassium. Because ARBs block aldosterone's effects, the body retains potassium. You must monitor potassium levels closely. Normal range is 3.5 to 5.0 milliequivalents per liter. Signs of hyperkalemia include peaked T waves on an EKG and muscle weakness. This is especially risky if the patient is also taking a potassium-sparing diuretic, like spironolactone. Second, high risk for renal failure. While ARBs help the kidneys, in certain high-risk patients, specifically those with severe complicated heart failure, the kidneys may actually rely on the RAS system to maintain adequate blood flow. Blocking it in these patients can sometimes trigger acute renal failure. Therefore, always monitor BUN and creatinine, your main indicators of kidney function. Third, high risk in pregnancy. This is a massive safety alert. ARBs are absolutely contraindicated during pregnancy. They must not be taken by women who are pregnant or planning to become pregnant, as they can cause severe injury or death to the fetus. Let's combine our side effects and education points, as they go hand in hand. The most common side effect is orthostatic hypotension, dizziness when moving. Teach the patient to change positions slowly, sitting up from lying down for a minute before standing to prevent falls. For potassium management, instruct the patient to avoid salt substitutes, which often contain potassium, and limit foods very high in potassium, like bananas, oranges, and certain greens, unless cleared by their doctor. Angioedema is rare but serious. It's a sudden, deep swelling of the face, lips, and tongue. While much less common than with ACE inhibitors, it is a life-threatening allergic reaction because it can obstruct the airway. Instruct the patient to call 911 immediately if they experience any swelling of the face or tongue or difficulty breathing. Regarding tapering and compliance, the patient must never abruptly stop taking the medication. Stopping suddenly can cause rebound hypertension, a dangerous spike in blood pressure. If they miss a dose, they should take it the same day. If they don't remember until the next day, they should skip the missed dose and resume their regular schedule. For blood pressure monitoring, teach the patient how to monitor their blood pressure at home and when to notify the healthcare provider, typically for a systolic BP below 90 or any reading significantly outside their normal range. Now let's test your knowledge with 3 NCLEX-style questions. Question 1. The nurse is providing discharge teaching for a patient prescribed losartan. Which statement by the patient indicates a need for immediate follow-up and correction? A. I need to avoid getting up too quickly, especially at night. B. I will stop taking my pills if I get dizzy to keep my blood pressure from going too low. C. I should check my blood pressure every day and keep a log of the readings. D. I can continue using my salt substitute, which is high in potassium. The correct answer is B. I will stop taking my pills if I get dizzy to keep my blood pressure from going too low. Rationale. ARBs, like losartan, must never be stopped abruptly, as this can cause dangerous rebound hypertension. The patient should call the physician if they feel dizzy or hypotensive, but they must continue the medication until a new plan is made. Statement D is also concerning, as ARBs can increase potassium, so salt substitutes should be avoided, but abruptly stopping the medication presents a more immediate and severe. Question 2. A 32-year-old female patient with chronic hypertension is prescribed valsartan. Which question is the highest nursing priority to ask before the patient leaves the clinic? A. Do you have any history of a persistent dry cough? B. Do you consume an average of 2 alcoholic drinks per day? C. Is there any chance you are currently pregnant or planning to be soon? D. Are you currently experiencing any muscle weakness or fatigue? The correct answer is C. Is there any chance you are currently pregnant or planning to be soon? Rationale. ARBs like valsartan are known to be teratogenic, causing severe harm or death to the fetus. Because of the patient's age and gender, assessing pregnancy status is the highest safety priority before dispensing the medication. Question 3. A patient taking an ACE inhibitor develops a non-productive hacking cough that interferes with sleep. The physician switches the patient's medication to candesartan, an ARB. The nurse understands that candesartan is being used because it A. increases the breakdown of bradykinin in the lungs. B. has a less pronounced hypotensive effect than ACE inhibitors. C. binds to angiotensin 2 receptors without affecting bradykinin levels. D. prevents the initial formation of angiotensin 2 in the liver. The correct answer is C. binds to angiotensin 2 receptors without affecting bradykinin levels. Rationale. The persistent dry cough associated with ACE inhibitors is caused by the accumulation of bradykinin. ARBs bypass the ACE enzyme entirely, which is responsible for bradykinin breakdown, and work by blocking the angiotensin 2 receptors, thus avoiding the bradykinin-related side effect. That wraps up our detailed review of angiotensin 2 receptor blockers. You've mastered the Sartan suffix, understood the RAS system, and covered the critical nursing responsibilities. Did you get all 3 NCLEX-style questions right? If you struggled with any part, let me know. We can dive deeper into the difference between ARBs and ACE inhibitors or review the signs of hyperkalemia. Great job, and I'll see you in the next video.